Hello friends, let us discuss CPR, Cardiopulmonary Resuscitation. Cardiopulmonary resuscitation is the first aid given to a cardiac arrest victim, and it is divided into basic cardiac life support and advanced cardiac life support. Basic cardiac life support is given by anyone, a lay person or a hospital person. Advanced cardiac life support can only be given by a hospital person. Okay. The steps of basic cardiac life support is very simple. Some basic steps we have to follow, and a good basic cardiac life support is foundation for a successful resuscitation in any person, right? So let us first talk about basic cardiac life support. What is this basic cardiac life support? Basic cardiac life support. As I told you, it can be given by anyone, a lay person or a medical person. 70 to 80% of the cardiac arrest is an out of hospital scenario. So lay public should also be trained to provide first aid to these victims of cardiac arrest so that they can be successfully resuscitated without any organ dysfunction or without any irreversible phenomena happening in them. Okay, so let us discuss about cardiac arrest. Cardiac arrest, what happens in cardiac arrest? In cardiac arrest, heart is not pumping the blood and it is not, all the other organs are not getting perfused. Cardiac arrest is different from heart attack. Heart attack is more of the blood supply problem, and heart attack can lead to cardiac arrest. But cardiac arrest has various etiology. Even a choking victim can go into cardiac arrest. Even an electrocution victim can go into the cardiac arrest. Due to heart conditions, heart diseases, one can go into the cardiac arrest. It is more of a rhythm problem in which heart has stopped pumping the blood. So what happens when heart stops pumping the blood, the organs does not get the blood and irreversible injuries to the organ will start happening. So there are some steps, some first aid kind of steps given to these victims which will maintain the perfusions of the organ and save the organ from irreversible damage, and that is what is basic cardiac life support. So I would focus in this section basically on the steps of BLS. I will not go into etiology. I will not go into the reasons why these steps are done. I will just focus on the steps because a lot of questions are being asked on steps of BCLS. So let's say whenever we get an unresponsive adult, right? What do? If I come across, let us start discussing with a scenario basis. I'm walking in a park and suddenly I come across a person who is unresponsive, who is lying down on the ground. So what do? First thing which I do is I check for his responsiveness. I loudly call him. And he is not responding. Then what do? The first thing, if I am alone, if I am the lone rescuer, first thing which I will do, I will call for help. Or if I am two person, one person will call for help and the other person will start resuscitation. Okay, so the first step is, in case of unresponsive adult, call for help. Of course, all these things will be done after checking the scene safety. So we have to always assure the scene is safe for both who is doing the resuscitation and the person who is getting resuscitated. So if this scenario happens in the middle of a road, I would not start the resuscitation there itself. I will pull the victim to the side. Or let's say if the same scenario is happening in a burning house, I will not start the resuscitation there. I would pull the victim away from the house. So first I have to ensure that the scene is safe. Once the scene is safe, I will call for help. Once I call for help, then I will check. I will tap the victim, and what I will do, I will kneel beside him. I will kneel beside the victim and I will check his pulse and chest movement for the breathing. So I will check pulse and chest movement for sign of breathing, for breathing. Now, three things can happen. The first, there is a pulse present, okay, and breathing also present, chest movement is also there. So pulse present, breathing present. What will I do in this case? In this case, I will make the victim in left lateral position. Left lateral, that is recovery position. Recovery position. Would wait for the ambulance to arrive. I would not leave the victim unattended. I would wait for the ambulance to arrive after making the victim in the left lateral position. Then let us talk about the second scenario. What can happen in the second situation? Situation 2. There is no breathing, no chest movement, pulse present. So pulse is there, but there is no breathing. In this case, after every 6 seconds, one breath is given. I will give one breath to the victim. One breath is given, and after every 2 minutes, pulse is rechecked. Every 2 minutes, pulse rechecked. So every 6 seconds I give a breath, and every 2 minutes I check for the pulse. Okay, so this is the second scenario. Okay, the third would be, the third scenario would be no pulse, no breathing. Okay, unresponsive victim, no pulse. I have done a scene safety, I have called for help, and there is no pulse and no breathing. So in that case, I will start with chest compression. I will start with chest compression. Okay, chest compression. Three things we have to do. We have to know about the ratio of chest compression and ventilation. I have to know the rate of chest compression, and I have to know the depth of chest compression. Ratio of chest compression has to be 30 compression followed by 2 ventilation. Okay, 30 compression followed by 2 ventilation. Every 30 compression is followed by 2 ventilation. Rate 100 to 120 compression per minute. So this should be the rate, 100 to 120 compression per minute. And depth in an adult should be between 5 to 6 centimeter. So there are few criteria for high quality chest compression. For the high quality chest compression, the rate should be for high quality chest compression. The rate should be 100 to 120 compression per minute. We should push hard and push fast. We should allow complete recoil of chest. Complete recoil of chest. Because when you are compressing, you are mechanically compressing the heart and the perfusion of the organ is maintained. And when you are allowing the recoil, the heart is getting refilled with the blood. So if you will not allow the recoil, the heart will not get properly refilled. So I would allow the refill. 4. Just adequate ventilation. Just adequate ventilation. So chest should just rise. I would not over-ventilate, because if I would over-ventilate, then what will happen? This will again decrease the cardiac output, because positive pressure ventilation can decrease the cardiac output because of increase in intrathoracic pressure, decrease venous return. So just adequate ventilation. So I'll do a high quality chest compression. Depth should be, as we have written, 5 to 6, between 5 to 6 centimeter, not more than 6, not a centimeter, not less than 5 centimeter. So I will do this chest compression and ventilation, a high quality, these criterias. I will do it for 5 cycle. 5 cycle, 30 compression followed by 2 ventilation. So we take our hand, go to the side of the patient, take a palm, put the palm on the middle of the chest, okay, and take the other hand, put it on the hand which is on the chest and interlock the finger. Keeping the elbow straight, I start the chest compression and allow the full recoil. I compress the chest, allow the full recoil. I do it for 30 times, and if I am alone, I go to the head, and after completing the 30 compression, I just leave the compression and give 2 breaths. How do I give 2 breaths? I open the airway of the patient by head tilt and chin lift, close the nose, take a normal breath and give the breath to the patient and see for the chest rise. I watch for the chest rise. Within 1 second, I have to give 1 breath, and other second I have to give the second breath. So I have given 2 breaths. As soon as I give 2 breaths, I again resume with 30 compression. Again a high quality 30 compression followed by 2 ventilation. We do it for 5 cycle. After completing this 5 cycle, what is done? Check pulse. Check pulse. Again the pulse is checked. Which pulse is checked? Always carotid. In adult, always carotid pulses check. So we check for the pulse. If we are 2 people, one will do the chest compression and other will do the ventilation. And every 2 minutes, they will interchange their position. Because whenever you are doing chest compression, it's a very energy consuming process, and your compression would get suffered if you don't interchange the position very frequently. Okay, so we check for the carotid pulse. We go on doing this till a help comes, an ambulance comes. I have already told the ambulance to come with a defibrillator. So I go on doing this till the ambulance comes. And when we check pulse, it should be within 10 seconds. You know, the gap between stopping the compression and resuming the compression should never be more than 10 seconds. So within 10 seconds, I have to check the pulse. Okay, let's say still no pulse, I will go on repeating the cycle. I will go on repeating till the ambulance comes. Ambulance comes. When the ambulance comes, I have already told the ambulance to come with an automated external defibrillator. AED arrives. Automated external defibrillator arrives. AED stands for automated external defibrillator. Automated external defibrillator. So AED arrives. Once the AED arrives, I will ask the person who has come with AED to attach the AED pads. You know, it's a very simple device. You just have to open the lid, and when you open the lid, what happens? That the device starts, right? It opens and it starts giving the command. And it has 2 pads, like it will give a command, attach pads. So it has 2 pads, and on both the pad already a picture is made where you have to attach it. It could be that you have to attach anterolateral or anteroposterior. There are two ways you can attach it, anterolateral or anteroposterior. And diagram is made on the pad where you have to attach it. So we attach the pads. Once I have attached the pad, right? Once I have attached the pad, then I stop compression, So pads attached, stop compression in whatever phase of cycle you are, stop compression and allow AED to analyze the rhythm. So to analyze the rhythm, for AED to analyze the rhythm, you have to stop compression. AED analyzes the rhythm and it will give a voice prompt, voice command. It can give two commands, shockable or non-shockable. So if AED says shockable rhythm, right? What we will do? We will charge the AED. We'll resume compression. And let AED get charged. I'll charge the AED. Once AED gets charged, it will itself pass a command, charged, right? Then what we will do? We will clear the victim, and give shock. I don't set what should be the strength of the shock or how much shock I have to give, how much joules I have to give. No, AED is already in adult a fixed amount of current would be given in the shock, right? So we cannot change the strength of current given through shock for the shock through AED. It is an automated external defibrillator and everything is already pre-feeded in it. So AED will give the shock. AED gives the shock. Immediately after giving the shock, I resume compression. I resume compression. Then we complete 5 cycles, 30:2. 5 cycles, 30:2. Once I have finished 5 cycles, 30:2, I check for pulse. Okay, check for pulse and let AED analyze the rhythm. If AED again says shockable rhythm, then then again resume compression, charge the AED, clear the victim, give the shock, again resume compression, complete the 5 cycle, again let AED analyze the rhythm. Let AED analyze the rhythm. Right? Let AED analyze the rhythm. Okay. So this would go on till the time AED is telling us shockable rhythm. Guys, remember, it is no upper limit for giving the shock. If it is a shockable rhythm, we can give shock any number of times. Okay. Non-shockable rhythm. AED says non-shockable rhythm. Right? AED says non-shockable rhythm. If AED says non-shockable rhythm, then we have to continue compression and ventilation. I have to continue compression and ventilation. So I go on continuing for 5 cycle. Again, after completion of 5 cycle, AED is attached. We will never detach AED. Let AED analyze the rhythm. Okay, let AED analyze the rhythm. AED again analyzes the rhythm. Again, it says non-shockable rhythm. It says non-shockable rhythm. We will continue with this. If any time AED says shockable rhythm, I will go into left side of the flow chart. If it continues to be non-shockable, I will go on with the right side of the flow chart. This is what is BLS. This is only what is BLS. See, in this, we are not trying to recognize the rhythm. I'm not trying to set the current for the shock. I'm doing nothing. I'm just, after AED has come, I'm just following the prompts of AED. and doing compression, ventilation. I'm just maintaining a high quality compression and ventilation. So guys, this is most important in BLS, that is high quality compression, ventilation, chest compression, high quality chest compression, and as fast as possible AED should arrive, right? So good BLS is the foundation for good ACLS. So till how long we go on doing BLS? We will stop only when, number 1, return of spontaneous circulation, that I have achieved ROSC, R-O-S-C, return of spontaneous circulation. ACLS team, Advanced Cardiac Life Support Team, ACLS team has arrived and taken over the patient, Third, scene becomes unsafe. Fourth, very important again, I am exhausted. The person who is resuscitating gets exhausted and I can't continue. Exhausted and unable to continue resuscitation. So in these conditions, you will stop the BLS. Let's say ACLS team takes over and then you have stopped. So let us talk about advanced cardiac life support. Now when ACLS team takes over, a lot of new things are done. Number 1, monitors are attached and airways secured. Let's say a monitor has been attached, ECG electrode has been attached, okay, and manual defibrillator is there. Manual defibrillator is brought. Second, advanced airway like ET tube or LMA, whatever we are in expertise, we put it. Advanced airway is secured. Third, intravenous line, IV line is secured to give emergency drugs. So these 3 things are done. And now again the management is according to the type of rhythm. So guys, there are 4 rhythm possible. So for ACLS, cardiac arrest management, there are 4 rhythm possible. Ventricular, fibrillation, pulseless, ventricular tachycardia, asystole, and pulseless electrical activity. These 4 rhythm are cardiac arrest rhythm, electrical activity. Okay. Now let us discuss the management. Ventricular fibrillation and pulseless ventricular tachycardia, they form the right side of the ACLS flowchart and they are managed in a similar manner. Asystole and pulseless electrical activity, the left side, and they are similarly managed. So let us first discuss how do I manage ventricular fibrillation and pulseless ventricular tachycardia. In ventricular fibrillation and pulseless ventricular tachycardia, the most definitive management is that we have to give shock, These are shockable rhythm. They are shockable rhythm. Shockable rhythm. So in this, what do we do? Chest compression continued at a rate of 100 compression per minute. 100 to 120 compression per minute, of course. Now guys, ventilation, the ratio is not followed here because advanced cardiac life support, advanced airway has already been put. So ventilation is separately continued, that at, let's say, 6 to 8 breaths per minute. So ventilation at the rate of 8 to 10 breath per minute is continued. Okay. Now chest compression is continued after 2 minutes of chest compression. We stop the chest compression and try to analyze the rhythm. If it is VF or pulseless ventricular tachycardia, we charge the defibrillator. These are shockable rhythm at 200 joules for asynchronized shock, right? We give shock. Resume compression and ventilation. Okay, resume compression and ventilation. Again, we do it for 2 minutes. Again, the same rhythm. We check the rhythm. Check rhythm. Check rhythm. Same, VF or pulseless ventricular tachycardia. We can give the second shock. Give shock. In meanwhile, we have charged the defibrillator. 200 joules, asynchronized shock. Again, for 2 minutes, compression and ventilation. Continued. Once I have done compression ventilation for 2 minutes, again I try to analyze the rhythm. Similarly, still patient is in VF or pulseless ventricular tachycardia. Again I can give shock and ask someone to prepare for emergency drugs. And after giving shock, I resume compression ventilation and give patient IV adrenaline. 10 ml, 1 in 10,000 dilution. Give full 10 ml IV adrenaline, 1 in 10,000 dilution. I give 20 ml of saline, bolus saline, and raise the hand. Okay, and I do it when I am doing the compression so that it goes into the circulation. When you stop compression, there is no circulation. So always give the drug while doing the chest compression. So I give it the first dose of adrenaline. After this, again for 2 minutes, after 2 minutes of chest compression ventilation, again I try to analyze the rhythm. Still in VF VT, I can give the shock. And again I can repeat a dose of IV adrenaline. IV adrenaline. Compression, ventilation, continued. Same dose, 10 ml, 1 in 10,000. Third, after 2 doses of adrenaline, the next drug which I will use would be amiodarone. If still the rhythm is same, I can go for amiodarone. Amiodarone, 300 mg IV bolus. This can be repeated. Once more. 150 mg IV bolus. Amiodarone is given only for 2 times. adrenaline and shock has no upper limit in VF and pulseless ventricular tachycardia. So I can go on giving the shock till the rhythm is VF or pulseless ventricular tachycardia. I go on repeating, I go on giving shock, I go on giving chest compression ventilation, and I go on giving adrenaline. So what is done in pulseless ventricular tachycardia? In pulseless VT or in ventricular fibrillation, they are shockable rhythm. So 200 joules of asynchronized shock is given. Second, drugs which are given in these conditions is adrenaline, the emergency adrenaline, 10 ml, 1 in 10,000 dilution, repeated every 3 to 5 minutes. And the third special thing which we do, we give drug amiodarone, 300 milligram IV bolus, and another dose 150 milligram IV bolus. So these are the three intervention we do in pulseless VT and ventricular fibrillation. Okay. Now let's say these are not returning the rhythm back to the sinus rhythm. Then we try to find the cause, etc., and try to resuscitate, know the cause, why this has happened, and try to treat the cause. Then try to treat the cause. Okay. Let's say the rhythm is asystole and pulseless electrical activity. Asystole means no pulse and no rhythm on the monitor. And pulseless electrical activity means no pulse, but there is a rhythm on the monitor, right? So asystole and pulseless electrical activity, or PEA. In this, similarly, we are doing compression, 100 to 120 compression per minute, and ventilation, 8 to 10 breath per minute. Rhythm is, I analyze after 2 minutes, I analyze the rhythm. I have attached the ECG electrode. It is asystole or PEA. I continue with compression and ventilation. They are non-shockable rhythm. And I ask to load adrenaline. I give, during compression ventilation, I give IV adrenaline, 10 ml, 1 in 10,000 dilution. I give it, again I give it during compression ventilation, again after 2 minutes, again I let the rhythm to be analyzed, same rhythm. I continue with compression ventilation and give, again after, if 3 to 5 minutes have gone, I give IV adrenaline. I can give IV adrenaline. I can give IV adrenaline, 10 ml, 1 in 10,000, every 3 to 5 minutes. I repeat, 3 to 5 minutes. I go on doing chest compression and ventilation and go on repeating IV adrenaline. No other drug, no shock. No other drug, no shock. Guys, in VF and pulseless ventricular tachycardia, there is a high chance that shock will convert the rhythm in sinus rhythm, right? But in asystole and pulseless electrical activity, we will never give shock because there is no activity of heart to get converted. In pulseless ventricular tachycardia and asystole, the only chance for revival is if we find the cause. So meanwhile we try to find the cause. So in asystole and PA, pulseless electrical activity, compression, ventilation. Compression, ventilation is done and only drug given is IV adrenaline, 10 ml, 1 in 10,000 dilution. No amiodarone, never, and no shock, no shock. So I go on doing this and I try to find the cause. So 5H and 5Ts. What are the 5H of cardiac arrest? Hypovolemia, hypothermia, hydrogen ion, that is acidosis, hyperkalemia, hypokalemia, hypoxia. So I'll try to find the cause, but what is causing it? Hypovolemia, hypothermia, acidosis. I will try to treat the cause. 5 T's, cardiac tamponade, then coronary thrombosis, then pulmonary thrombosis. T is for thrombosis, pulmonary thrombosis, thrombus, then tension pneumothorax, tension pneumothorax, and toxin. So I try to find the cause. Whether the patient has ingested some toxin, I will try to give the antidote. Thrombus, pulmonary thrombus is there, or cardiac thrombus is the reason. If we see it's a tension pneumothorax, we try to treat the tension pneumothorax. If it's cardiac tamponade, I do a pericardiocentesis, right? So I put a needle in second intercostal space for tension pneumothorax to relieve it. So I try to find the cause, and if until unless I find the cause, it is impossible to reverse asystole and pulseless electrical activity. Guys, it is always easy, comparatively easy, to resuscitate patient in VF and pulseless ventricular tachycardia, and chances of revival in them is better than in asystole and pulseless electrical activity. So this is ACLS. Now one advanced monitor has been added in ACLS. In monitors, ECG was there, capnography has been added. So what is the role of capnography in resuscitation? I have already discussed it in the chapter capnography, but here also I am telling that once we put the advanced airway like ET tube, capnography can be used to check the right placement. So always capnography is attached. Then second use of capnography is whether the chest compression is adequate or not, to assess the adequacy of chest compression. So when we are doing chest compression and we have a capnography attached to the ET tube, the reading of the capnography, either ETCO2, should be kept above 20 mm through chest compression, right? It should be kept above 20 mm of Hg. If it is below that, it is inadequate chest compression. And third, it tells the prognosis, whether the victim would be able to get resuscitated or not. For a long time, even on chest compression, there is no capnography, no graph of the capnography, then definitely there is no circulation and chances of resuscitation to be successful is minimal. Okay, so this advanced monitor has been added. Now IV access in cardiopulmonary resuscitation for ACLS, we always take a peripheral IV line. Now if I am unable to get a peripheral IV line, the second option for us is interosseous line, right? So second option is interosseous line. Now through trachea, if I am giving the drug, how much drug is getting absorbed, it has no accountability. So it is not a very preferred route. Okay, so either IV or interosseous line. Central line is not recommended. It is time consuming and we need a fast IV access. Okay, so this is about ACLS. So I talked about BLS and ACLS, and I told you that in BLS we are not trying to recognize the rhythm, we are not setting the current for the shock, nothing else, nothing, the voltage for the shock, we are not setting anything. Everything is what we are following is being ordered by automated external defibrillator. But in ACLS, we are more doing things by seeing the rhythm, right? And we are doing a lot of interventions. So BLS can be followed by any layperson also. It's very simple few things which you need to follow. Just the basic of the BLS is how to do, you need to know how to do a high quality chest compression. ACLS needs advanced medical personnel to follow it. Okay, we have to recognize the rhythm, we have to secure the airway, we have to give emergency drugs, we have to set the voltage for the shock, etc. This is what is ACLS. Now, what is the difference between pediatric and adult? I just want to tell you in BLS, in basic cardiac life support, I talked about adult. And in adult, I told that ratio should be 30 compression followed by 2 ventilation. Rate should be 100 to 120 compression per minute. And depth should be 5 to 6 centimeter. And the only pulse which you will see is carotid. You will feel is carotid. Okay. In children, what is the difference I am telling you? Children means 1 year to puberty. Okay, that is children. We can feel 2 pulse. We have 2 options, either femoral or carotid. If I am doing compression and ventilation in BLS, and if there is one rescuer, then the ratio should be 30:2. If 2 rescuer, then it should be 15:2, right? 15:2. The rate is universal, whether it is adult, child or neonate. The rate is universal, 100 to 120 compression per minute. In children, depth should be at least 5 centimeter, not let's say between 5 to 6 centimeter, above 5 and below 6, it should be at least 5 centimeter. Okay, or let's say about 5 centimeter, about 5 centimeter. If it is infant, that is excluding newborn till 1 year, excluding newborn. Okay, excluding newborn, pulse which we have to feel is brachial. Same if single rescuer, 30:2, and if 2 rescuer, 15:2. Rate is same, 100 to 120 compression per minute, and about the depth should be about 4 centimeter. Now these are the difference between BLS of adult, pediatric and infant. One more thing I want to tell you, the technique of chest compression. Technique of chest compression. In adult, we talked that we go for 2-hand compression. We put one palm on the middle of the chest, other above that, and keeping the elbows straight, we go for chest compression. So we go for two palm technique. Okay, In pediatric, depending upon the child, depending upon the age of the child, we go for single hand technique. Single hand technique. We go for single hand technique, right? Or double hand, whatever, depending upon the age of child. If it is infant, we go for chest encircle technique. We face the either we do by 2-finger technique. If we are single rescuer, then side of the child, I am at the side of the child and I am going for 2-finger technique. But if I am more than one rescuer, then one would give the breath and other would encircle the child from front, would take both the all the fingers below the chest and thumb above the chest and go for encircling technique. This gives a better chest compression. So infant, we can go for 2-finger technique. In case of single rescuer, and encircling technique. Encircling technique in case of more than one rescuer. Got it, everyone? So this is in the technique in infant. Now remember that always before starting the chest compression, you make the scene safe. Always make the scene safe and always put the patient on hard surface. Because if the surface is not hard, whatever chest compression you are doing, it would not do the purpose of perfusion. It would not serve the purpose of perfusion. So, chest compression should always be done on hard surface. On hard surface. Got my point? So this is we have to follow. And remember one more thing, that minimum interruption between the chest compression should be less than 10 seconds. It should not be more than 10 seconds. So there should be minimum interruption in chest compression. In chest compression, there should be minimum interruption in chest compression. Okay, so this is what we have to follow for CPR, cardiopulmonary resuscitation. In a very simple way, I have talked about BLS and ACLS. Well, here I have dealt it in a small topic, just telling you the steps and the drugs and etc. what we have to give. In emergency medicine, I have covered every rhythm separately, telling their cause, etiology and management, right? But most of the questions would be solved from this only, because mostly they are asking on the questions on the steps of CPR. And if you follow this, you will be able to solve the question. Thank you.